introduce Simon Moore from Cardiff University to start. And I'll let you introduce yourself. Simon is the head of the Crime and Security and Innovation Institute.
Okay, hello everyone. I've just shared my slides so you don't have to look at me. I'm in Cardiff University. I'm director of the Violence Research Group and co-director of the Security, Crime and Intelligence Institute. So the Institute is a sort of broader organisation interested in crime, misinformation, disinformation and such like things. But for the Violence Research Group, our main priority is reducing the number of people that end up in hospital because they've been exposed to violence. So we work a lot with emergency care and similar, and seek to understand the pathways into A&E, as well as what can be done to protect people and prevent people from ending up there in the first place. So shall I just plough ahead with my presentation, Sinead?
Yes, please. No, absolutely. Thanks a lot.
Cool. Right. All right. So when I was invited to give this talk, 20 minutes, I think, isn't it? I think that the idea was to talk more about the sort of methods that we've used in terms of data analysis and linkage, rather than the actual project itself. And I think what's really interesting about what I'm going to talk about is the way that the research questions were developed. So you can see at the bottom of the first slide there, PREVIP and EDVIPE. So PREVIP was a big qualitative study looking at violence prevention in emergency care. EDVIPE is a very data-intensive project looking at linked data to understand and evaluate whether violence prevention is successful in that context. Before I sort of wade on forwards, whenever someone stuck a new intervention or project or idea into an emergency department, it's almost always failed. And the reason is simple. It's because emergency departments are incredibly busy. Staff don't have time. They don't have the resources to engage. And as I go through this talk, I think one thing that really needs to come across clearly is that these violence prevention teams have engaged successfully and to an unusually high extent. So of the patients that they see, 63 are engaging with the intervention, which is quite remarkable. We do have a paper in press at the Emergency Medicine Journal, and there is also, oops, I'll press the wrong button, hang on. If I disappear, I'm sorry, I'm just stupid with computers today. So this is the write-up of the qualitative work that I was talking about. It's funded by the Youth Endowment Fund, and in there it does show clearly that there is an unusual amount of engagement around this intervention. So what do we mean by a violence prevention team? Funded originally through Home Office money and the police. They're nurses typically seconded in from the emergency department, and their job is to identify, support and refer any patients that are attending due to violence. They walk the floor, so they're as part of the clinical team. They're not only relying on referrals in, they can also go and investigate notes, which is an important feature. A lot of people can be very reluctant to disclose for a number of reasons. Their behaviour might be somewhat wayward, involved with the criminal justice system, using illicit drugs, but also conversely, some people, particularly young women with kids and so forth, they can be very reluctant to disclose violence because they feel there may be repercussions through the social services or others getting involved in their lives. So disclosure in emergency care is an issue, and for these teams to have overcome that is a remarkable opportunity. So, there we are. Short-term funding. They are nurse-led, so the nurses can investigate clinical records. Originally, these teams were set to look at attendees who were aged 11 to 25. 18 is wrong, it went up to 25, but now they deal with everyone over the age of 10 years of age. It's changed further more recently. They're now looking at kids that are younger because there's been a bit of an uptick in violence in primary school aged kids as well. And their focus really is preventing further engagement in violence. And what they do is they provide support to the individuals. They can refer them out into other services and various other opportunities. So, as I said, they do engage with patients very well. Um, they also train staff in the emergency department. So in an emergency department, you've got this continual influx of people. You've got trainees, you've got agency staff, and obviously over time, awareness of what the violence prevention teams will wane. So they're continually training. And it's interesting talking to colleagues in those environments because what they're saying is that their engagement more generally through training and support is increasing the amount of people that are identified for safeguarding generally. So this is a very important positive. Um, as I say, because they are investigating records, they're identifying more people than would be otherwise identified under usual care. And this is including people who have been injured through knife injuries. So they don't want to admit that they've been stabbed for various reasons, but these nurses are able to talk to them, build trust, understand their circumstances, and then work with them as champions of violence prevention in that context to support these people. So when they started, they were quite unique. Uh, what they've done is they've built a referral network over time. So there are two of these interventions. One's in Cardiff, UHW, which is a CVPT in a circle there, and in Swansea, Morrison Hospital, which is SVPT. And what we've done is categorize all the agencies that they are routinely referring patients in. And you can see it's over time it's exploded. So they're referring people into social prescribing, employer support, sexual assault referral clinic, drugs, alcohol, youth services, and so on and so on and so forth. So an important feature is that when patients are referred, very often, if they do get a referral, they'll be passed over and they'll go and meet someone and they'll answer all the same questions over again. Who might say, oh, we now need to send you somewhere else, and that somewhere else will ask all the same questions over again. And what this can do for some patients is re-traumatize them. So what the violence prevention teams do is support patients through these referral pathways and with their permission share minimum information so they're not having to answer the same questions over and over again. And this will help with engagement and it'll help support and help reduce the distress that individuals are subject to. So, as I said, part of this project has been engaging with public patient stakeholders and the rest. So Welsh Women's Aid, the Woolwich. So these are people who are experiencing homelessness and all the related issues that that entails, as well as young people. And various other groups as well. So we had a couple of PPI co-investigators and made use of the Prime Group's PPI group Super. And through this engagement, there are a few things that came up. One was we had one individual say that they went to their general practitioner, they said at home on being exposed to this, that, and the other, and left with a prescription for antidepressants. And then another situation is where someone went to the emergency department and went through treatment, etc., etc. But it wasn't until they were sat down with a trained counsellor that they realised that they were a subject to serious violence. There's this sense of normalisation in certain areas, in the sense that there are some individuals that think them being exposed to violence is just normal. But then also there are some practitioners who are unwilling to engage. It's not just general practitioners. My colleagues in safeguarding tell me but the number of safeguarding referrals made by community dentists in 2022 is zero, which is of course absolutely impossible, seeing as safeguarding getting about 4,000 referrals a year from the same area. So these are some of the questions that came up. But in addition, I'm not going to bother with that slide. This is it Friday. So this is just going back to the engagement and ascertainment that over time there was a bit of a bedding in effect that was apparent in Cardiff. So when they were first introduced, it took a while to get off the ground, and I think it really highlights the agility and passion that these nurses have for this role. it took time for them to engage with the clinical team, but once they did, it was ticking over very well. So yeah, so a lot of the questions that came out around this particular project came from that engagement, and what they started to ask us was to look at whether we could understand the location and circumstances that violence occurred. So neighbourhoods, licensed premises, schools. Big issue with schools, they do not engage. They want to protect their reputation. They're not interested. They're interested in who is contributing to levels of violence. So drug gangs, criminal and sexual exploitation is something of a significant issue at the moment, particularly for young people. They've seen cases of modern day slavery. They've also referred into the Prevent Counter-Terrorism programme as well. So these are all cases that would have otherwise been hidden away. And they're also interested in sort of patient characteristics in themselves. So they talked a lot about disability. So we're going to do some work about neurodiversity, personality disorder, ADHD, just to understand who these people are and how they ended up in the hands of the violence prevention team. And importantly, whether there were upstream opportunities to do a bit more to protect them. Because if someone's been diagnosed formally with a neurodevelopmental condition, they've been through the hands of a professional who could have perhaps pointed them in a different direction. So another stakeholder comment was just how valuable this information was, because these teams are gaining the trust of patients, they're listening to them, listening to their stories. And when anonymised and shared with partners, it can really make a difference in terms of the intelligence they have, because people don't talk to police officers, not usually. Well, I mean, they can, but not all the time. So there's some unique information here. But I think when we start to sort of turn towards the data and data analysis, we have to understand where that data comes from. So if we're talking about emergency department data, what does that mean? Well, the emergency department is the front door to a hospital, essentially. So let me give you an example. One of our co-investigators, David O'Reilly, devised the trauma network as it is in Wales and has since been replicated in England. And what they do is at the point of injury, if it's very serious, they'll look to stabilise that individual as rapidly as possible. That could be in a minor injury unit or a local emergency hospital. If they need further treatment, they could be referred to a major trauma centre. Orthognathics is in Morriston. So the point is a patient journey. They can go through the front door of hospitals on numerous occasions. So if we have one significant event, we are likely to see a number of subsequent events. Conversely, if someone's admitted into hospital, they should be referred straight to specialty rather than through the front door of the hospital again. So this introduces some interesting issues around censoring. So if we see a cluster of emergency department attendances in a row, it's likely that's attributable to the same event. And so what we would do is, if we're counting emergency department attendances, severity will be a covariate in that. So the more serious, the more likely it is we'll see more emergency department attendances. So we've had to work very hard to understand how this works in the data. So linking things like the emergency department data set, PEDU, and others, and censoring it as needed. Before I get to that, our analytic strategy is to use recurrent event analysis. So this is an extension of survival analysis, and what we're looking at is multiple failures over time. I've used this before. I really like it. It's quite adaptive, but it does produce nice graphs, which is half the battle, really, isn't it? So the one on the bottom right here, so this is the cumulative hazard estimate. And what it's looking at is the number of interactions for young people with criminal services. This is from an old piece of work that we did. Analysis time is in days. Apologies, analysis time is their age. And what this is that between 4,000 days and 8,000 days, which is about 20 years of age, these kids are interacting, these young offenders are interacting with the criminal justice system on average about 10 times. But what we were able to do is look at differences in their personality, in this case, low fear, high fear. And we find that those with low fear were more likely to carry on their criminal journey once they hit the age of 18. But the point is that we're looking at recurrent events over time. So this is why it's important to understand that multiple emergency department attendances could be clustered on the same event, and we need to adjust for that and censor as appropriately. So this is the graph that we put in the protocol. So we've got 5 patients here. Here, patient 1, they were born in Wales or moved into Wales at time 0, and then were still in the study at time 20, but no events occurred. Patient 2, they were born in Wales at time 0. There was an event at time 4, which led to them being in hospital or admitted for 2 days, and then they were released, and they were again at risk. And so as you go through these examples, what you can see is time at risk will systematically vary by the time they enter into the data, which we have to be aware of, which will be birth, moving into Wales. And when they exit data, that's death or moving away from Wales, and then intervals when they're admitted into hospital. And if we don't get this right, then we can inflate time at risk, which will skew our results. And time at risk will be related to the severity of the injury that they've sustained as well. So very important to get that right. What do we start to find here? Well, I've got some initial results to talk about. I'll focus mostly on Cardiff, where I'm more confident of what we've got. But what we're finding in Cardiff Accident and Emergency is these violence prevention teams are identifying an additional 44% of attendances as violence related. So these are people that are missed under usual care. When it gets really interesting is when we ask the data, well, who are these people that are missed under usual care? Men are missed more than women, young people more than elderly. People who are from deprived neighbourhoods are more likely to be missed, and people who are black are more likely to be missed. So there are significant inequalities in usual emergency department safeguarding processes that are being partly addressed by these violence prevention teams. We still think there are some out there who are not being identified. These may be people who are being exploited and attend with the perpetrators. People who are on probation, people who are engaged in the illicit drugs trade. We still think they are harder to reach and not appearing in our data, and that's something that we hope to look at later on. But the overall picture is that there's an additionality here of these teams in emergency care. No, I think that it is work in progress, but I'm very, very pleased with what we've done methodologically. I think it's a really good project that uses the data appropriately and makes sense. And it's also really interesting in the way that we've brought sort of practitioners and the public in as well to inform the steer. I'm really excited about some of the work that we've got planned. So Annemarie, one of Sinead's colleagues, is looking at a decision tree model to understand pathways into assault-related attendance in emergency care, particularly around the areas of autism, personality disorder and ADHD. I think that's going to be very telling.
Yes.
But my colleagues in emergency care are very excited because it's really unusual to see a violence prevention team and intervention in emergency care actually work. It's a rarity. So there we go. Thank you very much for listening.
So we can have questions at the end after we've heard from Annemarie, but Simon's work there links to GP, Ministry of Justice, hopefully soon. So multiple data sets to do this. So it's a big work. Thanks a lot. So yeah, Annemarie, I think, is going to talk to us about working with police data.
Hi everyone, my name is Annemarie Newbury. I'm a research associate in Cardiff University working in the violence research group with Professor Simon Moore. I also work part-time in South Wales Police. Let me just make sure I'm presenting the screen. So I'm going to talk about managing and accessing police data and some of the considerations you need to take when trying to gain access and using police data. Part of my role in Cardiff University is actually bringing police data into sales so that it can be used for different research projects. So just some initial thoughts on accessing police data then, and kind of like the best way to go about accessing that data if you want it for a specific project that you have in mind. So first sort of step really is it's important to obtain leadership and support within the police. Really those people will be the gateway into the police, and if you've got support from people at a fairly senior level, I'd say potentially superintendent level upwards, they can help drive access to police data. They can obviously can't cut through red tape, you still have to go through the information governance processes, but they can really help move things along a little bit quicker. Especially if they're able to demonstrate that sharing the data has a benefit to policing and aligns with some of their sort of ambitions within the force. It's also important to engage with police experts within the force. So these will be a range of different experts. There'll be data protection officers, there'll be force forensic sort of security officers, force security officers. Also, you'd have people within that given field who would have all the expertise on the area of policing that you might be looking at, be it, for example, missing persons, domestic abuse. Those are the people who sort of work in that area day in, day out, understand the victims and the perpetrators, understand the processes in policing and why things get done. So they'll be really helpful in also shaping that data set and what you might need from the data. Again, you need analysts who know the police systems, know what data is held within them, what can be extracted. They can understand how that data is recorded and how recording may change over time. Of course, then you have to go through information governance processes. Those are quite lengthy, sometimes depending on the sort of size and nature of the data that you're extracting. But often you'll need to complete a data protection impact assessment before a sharing agreement can be written up to outline what is shared, when, how, and all of that technicality. And then finally, engage with police experts post-analysis. So they'll be really useful in helping you understand your outputs and help you interpret what you're seeing and why you're seeing that. And also being able to translate that into strategic and operational sort of knowledge and potentially recommendations then, and also guide further research. So in terms of information governance considerations then, it's really important when gaining police data that you would consider the nature of the data set you want and the risk that data poses. Of course, non-identifiable data, so data that doesn't have any sort of locations, names, anything that could identify a person's, will be much more easily accessible from a police force and significantly reduce the sort of timescales you're looking at. If you're having anonymised or pseudonymized data, that can take a bit longer to obtain, and you do need to go through some data protection impact assessments for that. You need to consider the sensitivity of the data. So if you're asking for, data on domestic burglaries, for example, for the population within a given time frame, as long as you're not asking for names and addresses, generally that's a little less sensitive than if you're asking for data on domestic abuse incidents and victims' experiences of domestic abuse. You also need to consider if you're having a special category data, so that could be data on ethnicity, that could be data on political views, that could be, for example, health data on staff, or crime data. So crime data isn't special category data, but it has to be treated with the same sort of certain degree of sensitivity, the same as special category data. You also need to be considerate of whether you're using or seeking invisible data. So that's data that the data subjects are not aware has been collected on them. So it's not obtained directly from those subjects themselves. So that would cause a few more sort of considerations and risks from a data protection perspective. And then you also need to consider the volume of data. So that would be sort of the volume in terms of the duration that you're seeking the data. It could be the population size, it could be the number of variables. The more data you're asking for, again, the bigger risks that will be to the fore. So they'd look at additional safeguarding and secure for that as well. You also need to consider the nature of your processing. So if it's novel research, or processing, if you're using new technologies, if you're considering artificial intelligence, anything like that, that would need further consideration by a data protection officer or information governance team. So these can all, again, require further evidencing of those safeguarding measures. Data matching. We're looking now to link police data and sale. There are some nervousness and anxieties around matching police data to other data sets such as health and social care, because that could lead to people becoming identifiable within the data set. So all of this again requires further evidencing of those safeguarding measures. So these are things really that if you're requesting data, you need to be kind of really clear on what you're intending to do with the data. Impact on data subjects. So just be cautious. I mean, they are really keen to understand whether you seek to do any sort of profiling, whether you're looking to do any sort of public surveillance. So if you're focusing on certain areas and looking at levels of crime in certain areas, or automated decision making as well, and also tracking of people. Those need to be really well explained and understood within those requests for data. And then you also have to be really considerate of subjects' rights, so their rights to be informed about how their data is being used, their rights to access data, for data to be rectified. So, for example, we're looking at crimes subjects, so suspects of crimes and victims of crimes. When we extract that data, those crimes won't all have outcomes on them. So we are putting processes in place to go back and be able to update those outcomes in case, for some of those people are not considered to be guilty of those crimes, so it's not captured on their records. They also have the right to have their data erased, and also have rights related to automatic processing. So they want to know how you're going to be able to meet their rights. There's things that we can get around without sort of privacy notices and things that are kept on websites, and be able to include that. And they're also going to be really keen on knowing whether you plan on sharing onwards that data, because of course as soon as the police let that data go, share that data with you, they're not able to control that use of data. So you have to be super transparent on whether you intend to also share that data onwards. It's also really important for you to consider the feasibility of access to the data. So you need to really consider what are the sources of the data, what systems are that data held on, how is it obtained. So if it's held on systems such as the PNC, the likelihood is you're not going to be able to access that through a police force, because the data held on the police national computer is owned by multiple forces, and so the Home Office is probably where you're going to need to get that data from. Likewise, some systems within policing aren't designed to hold data that can then be extracted for the purpose of research or performance. So it's really important that you speak to those analysts and understand those systems and actually how feasible it is to extract that data, because the Force Information Governance team will never sign off on sharing data without real clear process in place about how that data is going to be extracted. And again, you need to consider whether there's any data that is restricted. So certain data sets such as intelligence, data relating to terrorism and extremism will be restricted and won't be accessible without considerable. I've never accessed that data, so I'm assuming it'd have to go at Home Office level. Just generally touch quickly on the legal basis for accessing data. I mean, I'm not a lawyer, and I also am not a data protection officer, so I'm not going to go too much into the specifics on legal basis. I always recommend that you speak to those who work within the sort of service that you're working for. But when you are looking at the legal basis, you really have to consider the purpose of data processing. Some of the challenges that we're having at the moment with accessing data to put into sale is that we want it for multiple research projects, not a specific project, which data protection officers are really struggling to kind of get past that, because the purpose for sharing the data needs to be quite specific. You also need to sharing needs to be necessary, reasonable, proportionate. So if you ask for 30 years of data, you really need to be able to evidence that that's absolutely necessary and proportionate. They don't want to overshare data, they only want to share data that is absolutely necessary for the purpose. And they won't share sort of everything with you. You have to be clear on why you want each variable, or what benefits that's going to have. You have to be really clear on the benefits to police, the public, and also to the subjects of the data. They want to know kind of what benefit that sharing will have, what your research will help them achieve, what benefit that'll have to the public and those involved. I've mentioned this a little bit, but obviously data subjects have the right to be informed about how their data is being used, so you need to consider how you're going to inform them. And they'll also want to know whether you're going to consider asking consent. If you're extracting big data sets, and obviously consent to have the data shared and used isn't realistic. However, that's what the DPIA is for. It's to overcome the safeguarding barriers for that, and also to cover the privacy notices and stuff. Data minimization. So this comes down to making sure that your data is adequate, relevant, and limited to what is necessary, as we talked about. And also for you to consider whether there's any other way in which you can conduct your research without the data. And then also to consider mission creep. So this is ensuring that you have safeguarding measures to prevent the widening of the use of data and the technology. And a couple of points on security. You need to be really, really transparent on the security measures that you have in place to receive that data and hold that data. So they're going to want to know kind of what certificates, code of conducts and accreditations you have, so such as Cyber Essentials, iOS accreditations, and various things like that. They want to know where you're holding the data, whether it's UK or international. If it's international, again, that poses a higher risk, so there may be some challenges there. I'd always recommend trying to have a UK-based platform to hold the data. They want to know, how are you going to safeguard the data? Who has access to data? Who's processing the data? Do they have vetting? Is it manual or automated processing? They need complete and utter transparency in that. So they need to know exactly everyone who's involved and what they're doing with the data. And that's all my...
Thank you. Thanks very much. Having said all that, I think we've had quite a bit of success in linking police and health data. And I think that's because the questions have come from the police end. So I think one of the most important things in what you're saying, in my opinion, Annemarie, is to very much work with the data providers on what questions are important to them. And I think that's across the board. That's not just the police. That's anywhere where you're trying to bring in local data sets or new data sets. You'd have to work with people as to, questions they're interested in. And so then a lot of the barriers that you've identified here are actually people help you overcome them because they would like you to use the data better. What's your thoughts on that?
Yeah, I totally 100% agree. And I know you've done projects where yourself, Sinead, where you've linked in very closely with people within the police force who are absolutely brilliant and, like I said, complete experts in their field. And they'll be able to provide a very good understanding and interpretation of the data. So yeah, I completely agree. I mean, I think also your success with getting police data into Sale has been because you've had a very specific project in mind, and so that's kind of allowed them to, the data protection, the information governance teams, to ensure their legal basis is correct. So they're ensuring that it's, you know, the data is necessary, it's adequate, they're able to make all those assessments. Whereas for us, obviously, trying to bring data into Sale as a core data set is challenging because it's for multiple research projects as opposed to just one, so they're not able to pinpoint those legal bases.
I don't know if anybody else has any questions at all. Anything you'd like to ask Simon or Annemarie? I mean, I think one of the other projects that's going on is co-production with people who are in these data sets. And I think that's one of the most essential things, that this isn't co-production with the general public. It's actually co-production with people who maybe have experienced homelessness, have been victims of domestic violence. So what they see as sort of for public good versus what they see as actually that's not for public good, and I don't want you to do that with my data. And I think those questions might be very different from what the general public would think was acceptable. So I don't know what Simon, you talked quite a bit about the PPI involvement in your work and how it's perhaps a bit different than what most people who are not in the data sets might think. What's your thoughts on?
Well, I mean, we've tried very hard to engage with some of those individuals who wouldn't typically involve themselves in a project, you know, particularly people who are experiencing homelessness, because they're a very vulnerable group. So they'll be familiar with illicit drug use and mental health problems, etc., etc. So I think that's where the sort of value comes from, because their thoughts and feelings about not only engaging with support, but also what they think would be important, can be incredibly valuable. And I think that sometimes as researchers, what we do is we are perhaps a little bit overconfident that we know the answers, because what's hidden and hard to observe doesn't it really creep into our narratives. And just building on what Annemarie was saying as well, that would include stakeholders. So a frontline officer will have thoughts about how things could perhaps be better done that doesn't necessarily ripple up or enter into what we're thinking and doing. And so I you know, back in the day, I thought, well, PPI is all a bit, you know, hand wavy, let's not bother. But some really, I mean, how would I describe them? I mean, I've heard things that have really changed the way I think about how stuff needs to be done. And really, you know, my position now is it does really need to come first. It absolutely does need to come first. And it really sort of goes to this issue that you can take a horse to water, but you can't necessarily make them drink. So you can come up with what you think is a wonderful solution to one of the world's problems, but if no one's interested in it, well, what's the point, you know? So yeah, I think that really needs to come first, and particularly when you've got big, complex, linked data, because what you see doesn't always make sense. Well, I could go into that.
Yeah, no. I think very much, especially in this area, working with other people to set the questions will make a big difference in accessing the data and actually understanding what you're finding, because I don't think it's straightforward. Does anybody else have any comments on that or any thoughts about that? So if people don't have any other questions or any things to ask Annemarie and Simon, I just want to alert you to next month's one is linking up with schools data and looking at the link of school and health data. Thank you everybody very much, and hope to see you again next month.